I'm John Odden with Collaborative for Universal Health. Thrilled to be here at the Wolfram Technology Conference 2019. I'm going to just share a few case examples of how Mathematica tools can help out in the U.S. healthcare system, filling gaps in information and producing better information that makes a difference in healthcare. Thank you. I'm John Odden, and welcome you to a little discussion of some experience from looking at basic algorithms for U.S. healthcare. I do that work on behalf of Collaborative for Universal Health, a small nonprofit that has background helping solve information gaps for hospitals, doctors, health plans, and life sciences companies, as well as quite a lot of attention to public health, a very interesting domain where we have a lot of critical outputs, very little funding, and precious few resources. A little bit of perspective to guide the discussion that I'll be sharing with you. There's obviously a national concern that we're putting a lot of money into healthcare to where at a macroeconomic problem, it's a challenging issue. There have been significant investments in getting the digital patient record into the system, something that has been going on for years and many have participated with good results, and also the occasional picture of physicians in white coats lined up for access to a keyboard. And there's the certified vendors of these digital systems, and comments folks make that these complex environments are kind of like a walled garden where it can be hard to get in and get out. And we've looked at how do you provide some missing information in that setting? And especially, can a small nonprofit actually do anything? And our perspective is that if you understand Wolfram research and Mathematica, it's possible. I do want to guide this with just a few observations that provide an orientation that's somewhat illuminated our approach and some of the choices we've made. One of them comes from a private informal course I once heard the Professor Richard Feynman giving, that the successful scientist must know when to discard the extraneous results. And some of that mindset came into shaping some of our choices here. Another is a work that goes back a while to Thomas Kuhn, who did very interesting things on how linguistics colors perception, which I think is actually at play in both scenarios that I'll share with you. And that one is how what we see can be influenced by what we've seen and understood before. And another one from a fellow who I was able to contract as a coach for the first outing of Health Information Exchange, who commented that innovation is not the problem, it's clearing the mind of the old ideas so that the new thought can emerge. And yet another one that I think is important in healthcare, where a lot of it is all expensive and big money, which is the late Professor C.K. Prahalad, a colleague of his, pointed me to this work and the idea that part of envisioning a successful future that's inclusive will be doing things in a way that, with profitable service, embraces the unfortunate, the unserved, and the many billions around the world who need these good solutions and good information, but don't necessarily have the kind of resource we have to afford it. So the first one looks at clinical practice guidelines. We went to the digital patient chart. It started years ago, came very quickly, lots of money invested. After that process, including the definition of the certified electronic health record came, we had affordable care, a political compromise. With affordable care, it became important to use clinical practice guidelines, something in the field of medicine that professors would develop, and as part of training the medical students on differential diagnosis, would help them know when to look at a clinical practice guideline, which would be a template for dealing with a particular condition. And the clinical practice guideline would give them some rule-ins, when to use it, rule-outs, when not to use it, some care selections, and some follow-up steps. And those would be typically printed. There's been projects in the recent time where, working under a contract with clinical practice guidelines, they would be laminated. And the physician could refer to them. And then their encounter note, which would be quite a lot of typing, would go into the digital system as a typed note, easily 500, 1,000 keystrokes. And what we did was just produced a simple Wolfram language script deployed with the CDF player to structure these. And that meant that even though the system that they're running, a very expensive digital system, does not know clinical practice guidelines, you could use the CDF, make the selection of how the particular guideline is used for the patient, paste it in, and proceed along the way. The traditional approach would be to spend into the millions of dollars to modify the digital system and attempt to put the pieces of each guideline within the digital system, which can work, and people would make that investment if they had the money, and they would then say, okay, in using our digital system, we follow the guidelines. But then there'd be the tiny thing, can you track the use of the guidelines? And when the guidelines are decomposed and spread throughout the digital system, there's often not the reporting to be able to know that. Whereas a clever thing, if you use a CDF and the consumption of a guideline that may have a few dozen steps is just a yes, no, which of the steps in the guideline were selected, it's a tiny little bit of data that can be safely stored in a data bin or anywhere that then reports across all the encounters use of the guideline. And it's also interesting that if you have a typical enterprise structure of a health system with the hospital and their digital system, many medical offices and their digital system, which could be dozens of different choices that each office would make, what digital system would they like? With an encounter note, each time the physician works with the patient, use of a CDF script allows across the whole environment a uniform way to just track, which guideline and what elements are used or not used and why at each encounter. So the question, does it actually work? The folks who used it and loved it were uncomfortable with me sharing any detail. Ultimately, the health system they were in decided to invest the big millions of dollars and script all the guidelines into the systems and give access to this common system to many, many physicians at no cost to the physician, which is an accounting problem for the health system, but it's kind of beyond our scope today. But we did find that it worked, and it worked very successfully, and we're considering, after this conference, offering the capability in a general way. And we believe that we'll be able to do that at whatever cost that the hospital would like. In fact, our initial thought was to tell them they can pick any price scheme they want, pay our nonprofit half for the service, and if they decide they want to give it away, that'll be okay. But if they call and ask questions, we might charge them. So that's one where we've got some experience. I wish I could show you more about it, but that has issues, happy to discuss further. But we did demonstrate that the CDF worked to augment the digital patient chart. The next thing that came along this spring was CMS, the group over Medicare and Medicaid, said we'd like to demonstrate some explainable AI that helps. And that was a very nice challenge. They put money behind it, and they said we'll even provide the limited data set of healthcare claims that you can use to provide a solution. So we were wondering, where would we look for a solution domain? And with some of the chief medical officers, which our nonprofit seems to collect, we state our mission and people show up, let us help you. We thought about it and figured we would go after opioid use disorder. We were coached that in the case of opioid use disorder, where billions of dollars are going into medication-assisted treatment as a bona fide way to help people stuck with opioid addiction to shift to a healthy outcome, that there's not a measure for success or failure other than the patient did not die. And that many of the public health studies that are looking at what is the success of the treatment programs are basically taking the single input of the coroner's mortality report to assess program success. So we were thinking maybe we could suggest a way to use claims and come up with a predictive measure of who might be at risk. Because if we're going to spend billions of dollars and we have the capacity to surge on individuals who might be at risk and we can get there soon enough, maybe we don't have to see them on the coroner's mortality report. So that was our proposal, that we could use a simple machine learning template that's built in with Mathematica. They would give us the data set and we would come up with treatment failure risk. Now there's you have to have been hands-on with the reality of the claims and the data and the medical ontologies and everything that's coded into that in order to perhaps pre-process it and run it in a tool such as we now have with Mathematica, but we felt it was worth raising our hand and saying we would like to go for it. We think it's possible. Now, the other thing we did is we said, because the standard in health analytics is a settled claim, where you give a claim where the hospital or the physician did something or the pharmacy dispensed something and there was a claim, there's a practice of waiting 90 days and working from the settled claim. So that's where we were thinking, well, maybe we could do a predictive model and validate it. Still, 90 days to settle the claim. And in the case of a dynamic health condition, that could be a bugaboo. So I had had a personal interest in these social determinants of health, which is all the information not in the medical environment, but available about the person that might be used to understand aspects of how they're doing. And so we also in our submission said, if you invite us to the program, we'll try to show that the 90-day latency claims are useful, but we will also try to show that we can find some of these social determinants of health, which can be available with a 72-hour latency, and you can even get it with 24 hours latency if you know where to look and the sources to hire. And we'll try to get a low latency model. I'll do questions. I'll do questions later. That'll work best. This time is tight, and we'll need to turn the room over in a short period of time. So we put that in, and what happened was the group doing the evaluation, you apply in February, they're announcing in June, and it got to be late May, and they said, oh my goodness, it's going to take till October to figure out who to permit to go forward with their proposal. And I would tell you that we're about to see Halloween and finish October, and I've asked them, do you think you're going to decide in maybe November, December next year, or are we just going to give up on the idea? They did have a foundation grant, a few $1 million to invite people to do this work, but they're choking on it. I don't know. But I do think that this kind of illustrates the challenge and the complexity of healthcare, especially in the US domain, where we are information rich in many ways, but sometimes you have to use some of the observations to be kind of like a information analytics jujitsu person and think very clearly and carefully about what are the goals, are other goals possible, what are the resources, and where might be the opportunity to use the kind of condensed horsepower that knowledge of Mathematica brings to potentially make a difference. So, and with that, we have time for Q&A, please.